Welcome to the latest episode of the Global Perspectives on Digital Health podcast. I'm your host, Shabs Upadhyay, physician working in digital health. So far, we've had perspectives from Brazil, South Africa, from Eswatini, and now we can travel across the Indian Ocean and get the perspective from the context of India. I recently moderated a panel around universal health coverage, comparing and contrasting implementation, impact from the NHS and India. And so I'm particularly interested in diving much deeper into this. I'm going to be talking to Ruchit Nagar. He is the founder of Khushi who've been working for the last 10 years implementing technology that supports community health workers and their impact on the last mile of health in villages in rural India. And there's a lot to learn for anyone building in this space. And we're also going to be getting some of the challenges that they faced as well that are going to be helpful for us all to unpack and learn from. So if you're building, researching or investing in this context or in a similar context, you'll find this one really valuable. Ruchit, welcome to the Global Perspectives on Digital Health podcast. It's an absolute pleasure to have you on the show and the first insights we have from the Indian context. Thanks for taking the time to join me.
Thanks for having me, Shubs. Really appreciate it.
So why don't we go into learning a bit about yourself, Ruchit, and how Khushi was born?
So Khushi this year is turning 10, and it's a big year for us, but we were born a decade ago in a class project. So I was an undergraduate student at Yale, and the class was set up as a design course. The first day of class, they gave us a challenge statement that 1.5 million children under the age of 5 are dying from vaccine-preventable disease. And it was our job to come up with a solution and business plan to take that solution out of the classroom and into the field. And then we went through a whole course of understanding design thinking frameworks, human-centered design, and the whole iterative approach towards studying a landscape, identifying opportunity spaces, coming up with rapid prototypes, speaking to users on the ground. Ultimately, we ended up focusing on data and accountability and working towards building a digital health tool to better track vaccine records in low resource settings, and especially in offline settings. And the initial concept that came out was a mobile application for the community health worker and a portable, wearable, NFC-based digital health record for the person receiving the vaccines, the family. And that was connected with an NGO that was working in Rajasthan, India, that was already giving services to areas that the government couldn't reach. But it was tracking everything on paper, and they were open to experiments. In fact, it's the same NGO, Seva Mandir, that had done the seminal work with Esther Duflo and Abhijit Banerjee that they talk about in their book, Poor Economics, where they studied whether or not giving lentils as an incentive could help improve immunization rates in that same area. So they had a precedent for doing research. They had a real need to better track the services they were providing, and then we were coming up with a solution. It was interesting that our team actually had no developers or computer scientists on our randomly assorted initial team. We were using open source tools like MIT App Inventor to code up a demo application. We ended up eventually applying for some funding on campus, getting that initial investment, and then setting up as a nonprofit organization. I sent 40 cold emails to local professors in Rajasthan to see if somebody could help guide us. One professor replied with their doctoral student at the time who was interested in mobile health. And that person, Shahnawaz, has been with us as the co-founder ever since, and is now the chief operating officer. So I would say it was a serendipitous start, and it took us to India. The thing that I take away is that it can really start from anywhere. I mean, in this case, it started from a class project, collaboration, students who are interested in public health and design, getting together and trying to, you have to have a little bit of a little bit of reckless abandon. You have to be a little bit naive to start to even approach such complex problems. And then the maturity comes over the next 10 years when you figure out how difficult those problems actually are. So that's kind of how it all really starts.
Okay, can we just go into the problem that you've touched on in terms of the problems with immunization, the problems that community health workers have? Can you just paint a picture of like the on the ground problem that was faced, both I guess on the community health worker and the healthcare delivery side, but also for like villagers and families who were kind of receiving this healthcare or in some cases not?
Yes. So when it comes to like what it actually looks like for people in these rural communities to receive access to healthcare, India has a decentralized healthcare delivery system. Every village has a locally elected community health worker. Every month, a nurse comes to each village, and she's responsible for 4 or 5 villages. And she conducts, with the help of that community health worker known as the ASHA, a maternal and child health and nutrition camp in which she will screen pregnant mothers for common conditions. She will give infants and toddlers their vaccines and track their growth and development. Now, whenever any mother, pregnant woman, or child is sick, they are referred from that screening camp to the primary health center where a doctor may be available, and then where they may be further referred to the district hospital. In a way, ever since 2005, when this national rural health mission started, India has had a very structured approach to ensuring that services have a way to, there's at least a structure through which services can flow. However, the challenges still remain that you need to have the right people. So even in the hardest to reach areas, you may not have nurses that want to deploy, for example. You need to have the right facilities and supplies. You need to have the right training for the personnel, right? You need to have the right data systems to understand what's going on. And that's all just on the supply side. And on the demand side, you're dealing with low levels of literacy. Before we even get to health literacy, we have low levels of literacy in general, then health literacy, high levels of multidimensional poverty. You have families that have migrant laborers. The families themselves are not living together as a unit. You have multiple kids in the household. Distance to the nearest facility it takes a long time. So you have, and then awareness and sociocultural factors that are also at play. Both demand side and supply side factors make completing the full recommended health journey difficult, right? Even if the services are all free. Mm-hmm. So what it takes to deliver a vaccine to a child, a vaccine carrier has to wake up early in the morning, go to the vaccine stock supply, bring the vaccine carrier to a more rural outpost that the nurse can then pick up. Meanwhile, in the village, the community health worker is going door to door and trying to make people aware that today there is a health camp and you need to bring, the pregnant women and the young infants to the camp. And then the health worker finally comes, the beneficiaries finally come, and the health worker is carrying, we still see this today, 10 different registers for different programs that they're responsible for, flipping through, trying to identify the patient, trying to update the records on paper, and then trying to make sure that they're giving the right medicine, the right vaccine to that beneficiary who's in front of them. So that process is incredibly taxing and time-taking. And that process still continues today. The thing that has changed over the last 5 years, I would say, is that in addition to those 10 registers, you now have 10 apps in your phone. So while before, it wasn't really imagined that ASHA workers would be using smartphones, digital literacy has improved. There has been definitely a sea change in that, but the work burden has only increased. And we surveyed ASHAs in Rajasthan, for example. The majority are saying that they spend 45 to 50 hours a month on data reporting related tasks. That's compiling the initial data, tabulating it into summary statistics, getting the required photocopies, traveling to the primary health center, sitting with the data entry operator, in some cases needing to give a cut of their incentive to the data entry operator or the supervisor. And ultimately, that whole convoluted series of steps takes 50 hours of their time that they could be spending with their family or with a high risk pregnant woman or visiting a newborn child or giving other services within their community. And there's over 1 million ASHAs across India. So the world's largest decentralized community health workforce is spending, we're estimating here, but could be spending up to 50 million hours or more on all these, I would say, low yield reporting based tasks that could easily be automated with the tools that they're already using if we're just able to intelligently design that system. And then the other question is like, what are we really incentivizing? Do they feel intrinsically motivated by the data that they're reporting that, hey, I'm going to report this data of these sick people in my community, that something is going to come back to me so that way I can better take care of them, so I can better prevent the same problems from happening again and again. That's the intrinsic value of the data that ideally you would imagine from a reporting type activity. That also doesn't seem to have the same level of real-time connect or real-time feedback that you would expect if you were the ones who are taking so much time to submit all this data. And then the incentives, what are the incentives showing? The incentives are showing that, hey, we need to be TB free by 2025. We need to, reduce infant mortality, maternal mortality. The incentives are not towards how can we best report the ground truth? How do we have the best quality maternal and child death investigations? So that way we can actually understand the areas that need more support. So we can actually get them more services, right? So because the incentives aren't looking towards improving health outcomes before understanding the ground truth, and because there's lack of supervision, and because anyways, these health workers are overburdened, all of the data that they're reporting is severely affected in terms of its quality and its usefulness. So these are the kind of deeper cutting problems that we see today, and that have kind of grown over time as we've tried to use technology to solve the problem. And when I say we, I mean the broader public health community, without necessarily designing the system in a way that can be horizontally integrated. In a way, we're making things more challenging for the health workers.
Man, you've traversed so many topics there. We will definitely bookmark the incentives piece and the goals. I wanted to just touch on a couple of things that you mentioned at the beginning. So just for those who are not aware, ASHAs are the name for the community health workers in India. Can you just kind of quickly mention exactly what that stands for?
ASHAs are Accredited Social Health Activists. They're considered to be the daughter-in-law of their village. So they have to be 18. They have moved into the village that they've been married into, and they're a representative of their village. So it's a democratic process to get elected. They then are responsible for health promotion, mobilization, taking pregnant women to the hospital to deliver, checking in on newborn children, and also screening for a lot of missions that are on the ground for all the different programs. So they initially, I guess the focus may have started with maternal and child health, but it really has expanded to 50 activities across every single health program.
Okay, next bit that you mentioned. So you mentioned 50 hours are spent on data entry, right? Across multiple platforms. And so is that per month?
Per month.
Per month.
Yeah.
So, and then you said there were how many?
Over 1 million in India.
Yeah.
Yeah.
And so, I guess you can extrapolate then the potential cost of that, right? That time that could be used better in other means. Thank you for highlighting that problem. And then I think the other thing that you touched on that Echo in Eswatini mentioned was all these different layers that are, at least on the supply side, in terms of like the delivery of healthcare, that are important to consider, and they're so intertwined with each other. So you mentioned the people aspect, you mentioned the facilities, you mentioned the supply chain, you mentioned then the data systems and the infrastructure, and the technology then kind of sits on top of that, right? For those who might not be familiar, can you give us a quick whirlwind tour of like what is the backbone system of digital health infrastructure in India?
Yeah, so the way that digital health evolved in India, it started in a vertical approach. So you had the reproductive child health bucket, had its own portal that was developed. Initially started at the state level, then it was adopted by the Ministry of Health centrally. Later, you saw the National Communicable Disease, the non-communicable disease bucket also develop out its own portal, focusing on things like diabetes, hypertension, oral, breast, and cervical cancer. And then you had a third bucket that was looking at communicable disease. So, vector-borne illnesses, for example. And a fourth bucket that's somewhat related, but was just exclusively looking at tuberculosis. So these four buckets they've built out their own solutions, initially building out web portals that data entry could happen in, and then moving into applications for the nurses, and then now moving into applications that could be used by the ASHAs. They also have different portals that would work at the facility level, like the district hospital or the primary and community health center. So now you're in this world where you have all these apps that are getting to the most decentralized health worker. But the problem still remains is that, okay, I could have a patient, for example, who both has a non-communicable disease issue like diabetes and is in my maternal health tracking system. And I need to now keep track of them in both places. I have to enter their data twice. People don't fall into just one bucket at a time. So there has been a push now to say, hey, and we're just talking about the government public systems right now. We're not even talking about all the private systems that have mostly been, kind of paper-based tracking for a majority of the private providers. The major hospitals have adopted, electronic health registries, but it is a very fragmented ecosystem. So what did India do? Beginning in 2018, they came out with something called the National Digital Health Blueprint, which has now moved towards creating an ecosystem in which all information systems can speak with a common language, which is the FHIR, using FHIR as a standard to actually communicate between different systems, whether they're public or private, to have a new universal health ID, and to have universal registries for both the facilities and for the providers. This way, at least the information exchange can be done in a more systematic way. And that way you don't need all these custom APIs or custom channels to share data between system one and system two. There's a common way that you can share that data to the universe, and then whichever system that needs it can pull. So, and they want it to be patient consent driven, which is great. They want it to be federated and decentralized. So there's a lot of great properties around how it's designed. The interesting piece is that it still was envisioned to be designed for those people living in the tier 1, tier 2 cities who are accessing, these are the upper and middle upper parts of that population wealth pyramid, who have access to smartphones, who are digitally literate, who are health literate, who are already using things like the unified payments interface to send money from person to person. Those tech savvy people would also have a digital record of their health information. So that's kind of how it was initially conceived. It wasn't initially conceived to figure out, hey, how are we going to work with people that may not have smartphones, may not be digitally literate, who are availing free services from the government? What are we going to do for them? What does consent look like for them? It wasn't really designed for the bottom. So now they're trying to work. They're working top down, thinking that it's going to get to the bottom eventually. But now they're starting to realize that, hey, we need to kind of rethink what it looks like to work bottom up. We need to rethink what it looks like. Instead of having all these 40 different applications and portals, let's work on making a connector application that can link to their different apps. Or can we have an integrated application that replaces all the redundancy? And that's ultimately what we're trying to do with our solution, which is called CHIP, Community Health Integrated Platform. It takes the 800 public health indicators that these health workers are responsible for, the ASHAs and A&Ms, and it simplifies it. It gets rid of about 150 redundant indicators, and then it streamlines it in a process that it's a one-stop solution for that health worker, and it covers all of her work-related requirements. She has something called the integrated work plan that she can click on, and she can see, okay, which houses do I need to visit today? And it tells her the breakdown by the different program. Which houses do I need to see in the week and in the month? And for every patient that she goes to, there's all these kinds of custom decision support that's based off the national guidelines, based off that program, so that she can then figure out how to refer, and the next person in the referral chain can also see the relevant information. So this is what we think would actually be helpful. for somebody on the ground who is responsible for covering so much of primary healthcare.
And just to draw a parallel, I mean, most of healthcare is clearly delivered by ASHAs, right, in India and other types of community health workers elsewhere. There's a real parallel with kind of clinicians working in Europe or the US or the UK of like, this overburdening of the electronic health record. And it's really important that, in the so-called Western context, we're really focusing on the value proposition that we're trying to offer or that we should make sure we think about is clinician well-being. And I just reflect back that, most of clinical care is being delivered by community health workers. It's important not to, I guess, like forget because we just think about, doctors or nurses in terms of clinician health well-being and make sure that actually the people who are out there really at the last mile of healthcare are really benefiting and feeling fulfilled in their roles, like just as any other healthcare delivery person would. So I think you've called out an important thing there. And whilst there are parallels, it's kind of unique to this context, right?
Yeah, I feel like the Western example and being like a resident doctor here, we spend 2/3 of our time in front of the computer and not at the bedside. And I think it's a cautionary tale, but
Yeah.
I'm not sure if that caution is being heeded because the same over documentation and almost overuse of these digital health technologies is being now applied to community health workers, where really you want them to be the least burden so that they can, their work, their counseling, their mobilization is really the thing that's reducing infant mortality and other key health metrics. So it needs to be simple, user friendly. The main, if I were to pick two indicators that are important, is how much time are we actually saving for them? Number one. And would they recommend this system to their peer?
Yeah.
If not, then we are not actually adding value. And even if the system is great, if the system is the 14th app that they're going to give, even if it accomplishes everything that it needs to alone, unless you get rid of those other 13 or figure out a way to restructure that so that those legacy portals can still get the data that they need and still function in a reasonable way, again, you're not going to be solving the root of the.
And what you're really trying to do, if you go to the meta level, you're trying to find the real drivers of the outcome. Like, what are the levers that you need to pull, right? And here, clearly, you've identified that a big lever is actually ensuring that us as community health workers can just get out and like get out their way, like just let them go and do the work, right?
Yeah, and I mean it's interesting because it runs counter to what people, all the buzz is about, where all the, a lot of the global health investment now, where is it going towards? It's going towards digital health, AI for health. We have to be careful that, are we actually, and then there's also quite, funders will put in hundreds of millions of dollars towards these initiatives, and then, have these expectations that capacity gets built and that governments will adopt these solutions and build that capacity to move them forward. But at the same time, if you look at how the funding is being distributed, it's not pushing us away from the siloed systems that we live in. Like there's funding that the funding is going towards a vertical solution for immunization or a vertical solution for non-communicable diseases, et cetera, et cetera. And that is just making the problem because then those large agencies then have a vested interest in continuing that vertical pipeline of control in a way to ensure that they can report what they need to report and show that their solution is successful. So I think really we need a radical rethinking and an honest conversation about what does collaboration look like. Not everyone needs to be a digital health expert. We have, again, a lot of the important work will require other public health technical expertise to better implement programs on the ground. The opportunity that I see for digital health is, first of all, if we do it correctly, if we align if we make the system ink-free so they don't have to use paper, that's the first promise of digital. Two, integrated or interoperable so that way we don't need a million different applications that are falling on one person. And three, properly incentivized so that way health workers, incentives can be social incentives, financial incentives, or even just productivity incentives that, hey, I did something and it felt useful to me. These three I's of ink-free, interoperability, and incentivization are the three pillars that we think are required to have a successful digital health solution rolled out and taken up. And then after that, the hope is that it can serve as a way for us to get better data of what's happening on the ground, better identify health inequities, better allocate resources, better allocate, capacity building for the people on the ground. So that way we can overall kind of move the health system in the right direction. But the way that I think about it is like you're literally having to renovate a house and redo all the plumbing, which is very, very messy and difficult once the plumbing has already been placed.
Yeah, definitely. And if you're just thinking only about certain verticals, like just the plumbing for the toilet, or
Yeah.
just the plumbing for, or just the heating or the pipes for this radiator, you lose sight of like, oh, how this house is not very heating efficient for some reason. Why? Right. So I guess that's a nice parallel. So we got Ruchit's three eyes.
Ink-free, integrated, and incentive.
Perfect. Okay. That's really nice. I want to backtrack a bit. We talked about how you identified the problem. And as part of that, what was your approach, especially like, because we've already touched on how you found what the levers were to driving towards like real outcomes. You clearly had to speak to the right people. How did you go about kind of delving into and really understanding what was going on the ground there?
Yeah, so that I think that's we talked about like we did this human-centered design course, and that was the initial seed, but the human-centered design didn't start until we actually went to the field and actually, walked alongside our community health work partners, right? Those insights were tremendous for us, and actually we built it into our team structure from the very beginning to have a field monitoring team, to have a community engagement team that functions through a call center. And on a daily basis, we are in touch with anywhere between 100 and 500 community health workers on the ground. And that's been for the last, 7-8 years. So you can imagine that is a wealth of wisdom that we're able to then understand from. And we're able to better design the solutions to actually help address the needs of the people that will be using those solutions, which I think is so critical. Most of the vast majority of software that is being developed for community health workers, those engineers are not meeting the end users. I can tell you that. And it is so critical to understand what actually works, what is actually helpful. You have to see both the trees, and then you also have to see the forest, right? Because you're also building for a multi-stakeholder environment where the community health worker is the end user or is the person who's using the app. But then you also have these public health officials that need to receive certain data, receive certain insights and reports. So they're a different type of user. And we can argue about how much of that data is actually useful, but until the national health policies and guidelines change, we have to also satisfy certain of those requirements. So we also have to work in the health department. We also have to have our team of policy and program focused people that are also available. So it's really a mix of both, being able to see the forest and the trees. And Khushi Baby's like interdisciplinary team composition is really what I think is our secret strength or our special sauce, because you have the field team, the policy team sitting side by side with the design engineering team as well. We have a team for monitoring and evaluation and data science that can help understand whether or not what we're doing is actually making an impact or not, and can be critical of our own approach. So you need to have all those different components to actually kind of have the end-to-end perspective of what it takes to roll out not just a digital solution, but a digital health solution that makes an impact.
Yep. And you mentioned that kind of when you initially started, you had this digital health record that was like via NFC for the community. You had the community health workers who had the digital health record. Is there more that you've built around that? Like, what have you got implemented right now?
So this whole project started off with tablets for nurses. These, I'm actually wearing it right now. This
Nice.
digital health necklace. So tying the tradition with the technology. The black thread was thought to ward off the evil eye.
Yep.
And these voice calls in the local dialect for the families. And it was focused on immunization. And we were working with one NGO. That was how it started.
Mm-hmm.
Then the next step was for us to move from NGO to government.
Yep.
Then we expanded from immunization to all of maternal and child health, because we understood that the nurse is not just doing She's not just giving vaccines to the kids, she's also checking women at the camp. We did a 2-year randomized controlled trial to get evidence to see if that modified system would improve immunization outcomes. We were able to show that, yes, we were able to improve immunization by 12 percentage points in our treatment group. We took that out.
Have you got a link to that so we can share that out?
I'm happy to share that.
Yeah, we can share that out in the notes as well. Yeah, perfect.
And so we took that evidence and we went to the State Department of Health. We say, hey, we want to scale this up. And they said, well, we've got 5 other projects for you to work on first to gain our trust, and also help us figure out this whole mess of 40 different portals that don't talk to each other. So we're like, okay, we'll start to work on this. And that's when COVID came. And then they said, hey, we need help with somebody to kind of help us screen the population for COVID at large. So we ended up making a decision to then move away from tablets, move away from these necklaces, move towards just the most scalable Android application that can work on any smartphone, because we didn't have time to procure all these different things. That wasn't as scalable. So that became we had to rethink our approach that, hey, this might be our USP of our system, that it's the digital health record adds to some level of accountability because you have to physically scan it to update it, means that the health worker met the patient. So we were really looking at the accountability lens, but you were losing off on the scalability lens. And in the time of COVID where you have to do a mass screening, you really need to have a solution that's more scalable. So we said, okay, let's pivot. Also, we have to pivot our focus, like the maternal child health focus. We make decisions to say, hey, we want to go beyond this because that's the need of the hour.
Yeah.
Apply what we've learned. So then we went through COVID. We helped do the screening. Because of the situation of the pandemic, a lot of the red tape was removed to allow us to get into the Department of IT, the State Data Center, to scale this thing up. And what ended up happening was not only did we screen for COVID, but we also screened for all those comorbidities that make COVID more risky. And a lot of those comorbidities link very well with many other different programs like non-communicable diseases, TB, et cetera. So now you have a database of 14 million people. You have 60,000 community health workers that have used the platform all of a sudden. And we're able to go to different vertical health programs like TB, like non-communicable disease, like vector-borne disease, and say, hey, we have this base. Let's build on top of it. And one by one, we're starting to add the puzzle pieces and starting to now use the data to support their programs, to use the data to study what is working within their existing interventions. So for example, with the TB department, twice a year, they screen for TB across the whole state. And they'll have ASHAs go and ask people for symptoms that are related to TB. And we're able to see the efficiency of the screening in vulnerable groups versus non-vulnerable groups. And because we've already done this effectively a digital health census, we're able to pre-identify who is vulnerable and help prioritize them because they're 6 to 10 times more likely to turn up to be a positive case. And we can show that evidence to help affect the policy and move the policy towards something that's more evidence-based. Of course, that requires advocacy. It's an ongoing process, but the data is now available for us to start to make those types of data-driven arguments or positions to help inform policies. So that's the bucket that we're in right now, which is really trying to use data for health system strength.
So that's really interesting. So you had to kind of there was the need of the hour with COVID. You then kind of the work that you did kind of helped also reach and make people who were maybe initially not visible in the data, i.e. the vulnerable populations, visible in a relatively usefully granular way. And therefore you were able to then kind of help decision making, targeting of resources, and also start to make more visible the discrepancies in terms of health inequalities, etc. I mean, that's not the summary of like what you did, but I just wanted to kind of touch on that little nugget of what you said, because I think that was really important.
No, and that's huge. We really considered the community health worker to be the local researcher of their village, the local reporter or journalist of their village, right? And there's an old Sanskrit saying that I don't know the exact original vocabulary, but and Nehru repeated this in one of his speeches. It says that the taste of the water changes every few miles. And we can literally now map that because we have tens of thousands of ASHA workers who are sharing data. The data that they share on social determinants of health, we think is very high quality and very rich. And you can literally see the tapestry of different degrees of poverty change from as you go from a few miles out to the next few miles out, literally kind of reinforcing that concept that India is not a homogenous place, right? And village to village, you're going to see differences. And to have a strategy that can now boil down to the village and get closer to the people is ultimately what we're striving for. That social determinants of health data also has positive externalities. It can be used by other departments as well to help with their planning. If I know that the poverty index is high here, I'm going to use it for my education, for my public distribution, for my other departments as well. So this is the new power of big public health data that has the potential to be unlocked if we're able to properly kind of enable community health workers on the.
Really, really nice takeaway there. So that was a technology layer. I want to go to the people layer and incentives, and maybe we can envelop that into kind of the next part of the conversation I wanted to get into, which is what challenges have you faced? So we've touched on like the problems you were trying to solve, some of your approach and really understanding the reality of like how care was delivered. And we've talked a little bit about the impact that you've had, etc., and how you've scaled. Where have you seen difficulties, challenges, and what you've learned from them?
I think, I won't start with the challenge. I'll start with the solution. The solution is that you have to be persistent and consistent, because it takes a long time to rework the plumbing, to rewire the system. I think, of course, politics is at play. There are vested interests, there are legacy platforms, there's funding that is supporting preserving a lot of the status quo. And, once the central government says that, hey, we want to roll out this vertical solution nationally, irrespective of you trying to have a more integrated solution on the ground, by default, you're going to have at least two solutions, right? You're going to have to break the workflow to use this vertical solution for objective X.
Mm-hmm.
We're seeing that in the case of immunizations right now, that the success of India's effort with the CoWIN platform, which was used to generate over 2 billion COVID vaccine certificates digitally and track COVID vaccination very successfully, and even share that as a digital public good to other countries as a form of even global health diplomacy. A huge success story in a way, now being expanded to cover routine immunizations across the country, a very noble and important goal, but again, still working within a silo. So how does that silo ultimately boil down to the person who has to now juggle 10 balls at the same time? So the question is, hey, can you get the data that you want, but can we think about doing something different at the ground level? Can you share us the APIs, or can we use a common language to talk, so that way a different system on the ground can still give you the data that you need to make your analysis and decisions? The frustrating part is that it should be easier to integrate between and across systems. The challenge is that there is some resistance, and there may be also gaps in capacity to facilitate those connections from a technical capacity standpoint. And if people are looking to invest, I would look to invest specifically in supporting connections across platforms, as opposed to investing in developing new ones. That's the major takeaway that I would recommend for those who are out there who are looking to kind of continue to support these initiatives. And I think the other challenge really that we are seeing is change is slow. We came into the government, we were very disruptive. Their internal Department of IT and other development agencies that have been there for 10 plus years, they were all skeptical of us. We've had to prove ourselves in a way, but we are impatient as well. We want things to change faster. But in order for things to actually change and durably change, you have to get your system, you have to get your gear within that whole machinery. Once it's in, it's very hard to then remove. But the conditions, like we talked about, need to also be in place for that gear to even turn. So getting the right mandates at the policy level, the right incentives, and then the right kind of collective buy-in to work towards a common solution, that is kind of an ongoing problem. And the approach that we're now taking, so we've worked in Rajasthan, India's largest state, but we're expanding to two new states as well, Maharashtra and Karnataka. Collectively, 250 million people live across these three states. Mm-hmm. The other two states, our approach and kind of criteria for even entering, is there a demand coming from the public health department, from the government itself? I think that is the single most important factor that's going to determine your success and timeline. Even more so than capacity or technical capacity, is what is the demand of those senior bureaucrats, that public health department, to actually move towards this direction. Now, those bureaucrats may change. There is cycling.
Yeah. So what does the signal look like for you to then say, okay, it's worth going for this, or we should focus our efforts here?
I think, again, you have to reach out to those senior health secretaries, women and child development secretaries, chief secretaries, and mission directors, and pitch and see if there is some buy-in, or if in some cases they have their own call for proposals that, hey, we want this type of system. And they, in the case of Karnataka, for example, they said, we're going to have a competition between 4 different players to make an integrated solution. We're going to select after 6 months, and then we're not going to pay you. We're going to expect you to help us for the following 2 years, and then we're going to ask you to leave. So that way we have the internal capacity to move it forward. And I think that's a very progressive approach towards taking ownership and accountability over the digital public health infrastructure that they're trying to adopt, right? So if we can be a facilitator of that we'd love to be contributing in that kind of environment where it's evidence-based and demand is coming from the government itself.
Great. Okay. At the beginning, touched on this incentive thing. So let's visit it now because it feels like a challenge too. You mentioned kind of, it's kind of related to that political aspects as well. Often you have certain big goals, and how do you make sure that the incentives of those big goals align with like the realities on the ground of delivering care? Because if they don't align, ultimately you get a very skewed or not very real picture. Can you elaborate on that?
Yeah.
Do you have any insights there?
This is the hardest question. Everyone asks, how are you going to make impact? What's your sustainability model? And it's we need to almost rethink about what is the context that we are working in, right? The goal for us is not to become the next tech giant or unicorn, right? That's not our approach to sustainability. Our end game is to really have a system that can strengthen the public health department, that they can own and feel accountable over, and they can ultimately start using data more effectively to help with their decision making in a way that they find valuable, and in a way that we can actually measure that says that, hey, we were able to improve the ground truth reporting, stage 1. Maybe the indicators got worse during that first stage. Then stage 2, we had a mechanism to actually see which interventions were working, and we actually used that data collection platform to test, okay, does giving a new mid-level provider at the primary health center improve healthcare utilization and decrease out-of-pocket expenditures? We actually did that study based off our data with the support of JPAL. We were able to turn our platform into a measurement tool. So that's phase 2, starting to see what actually works based off the interventions that you're putting out there. And then phase 3 is then replicating those interventions on the ground that have shown efficacy, and then seeing the overall indicators, which initially went up because you had more transparency, start to now go down. So those are the 3 kind of phases in like the evolution of the impact journey. And we're still very much in the first phase where we need to just better report the ground truth.
Yeah.
That's not going to look good to the government. That's not going to look good to the donor.
This is the thing, it takes time, right? So it's like, well, if you're trying to show ROI within a year, like you're missing the bigger picture, right? So
exactly. And the other thing is, certain donors talk to us and say, hey, you need to build capacity within a few years and then hand it over. But the reality is that we really need longer timeframes. I mean, even if you think about the West's adoption of electronic health registers, didn't happen overnight, right? It was at least 10-year journey, maybe 15-year journey for that to kind of fully transition to the level of adoption that it has now. So you can
there's
imagine
still many problems.
there's still many. It's still it's so convoluted. So you can imagine that it's going to be an ongoing. In one of the interesting examples of this is now you have this whole new momentum towards AI for health, right? What capacity does the government already have in AI for health or climate and health, right? How many climate and health, climate AI and health, or AI and health experts already exist? It's an emerging field, generative AI. How many of those experts exist? These are all new fields, new technologies that are emerging. And we expect the government, we expect the ethical review boards to just magically have capacity on how to evaluate and adjudicate and regulate those things. So they themselves are trying to figure out what's going on. There's a lot of gray area. Some people are taking advantage of the gray area. I think it really, we need to be very responsible in terms of how we state or overstate the impacts of these new technologies. We again need to go back to first principles and see that, hey, okay, I'm making an AI for health tool to help with diagnosis of disease X that can fit into the health worker smartphone. Is that going to change? How is that going to change her day-to-day activities? What if there are more false positives that get screened because of this tool? And is that going to actually meaningfully improve the referral rate? Or she's still going to tell everyone to go get referred, but the real challenge is the fact that they don't have transportation to get to the facility. That fancy AI tool may not be, it may be okay, but it may not be really solving the problem in of itself. So we need to understand the full value chain and go back to first principles to really ground ourselves in a lot of these new developments that are coming through. And I say that speaking from a team that is working on those same technologies. So we worked on the digital health solution piece. That's the first bucket. The health system strengthening is the second bucket. And our third bucket is research and innovation. So we are very excited and we think that there's a lot of potential that can come out of these technologies, but we have to also be very careful and responsible about how we study. I mean, it needs to be research. You need to do trials. You need to do qualitative research as well. It needs to be kind of done in a limited and carefully scaled way, because otherwise we're just going to overstate the value, and then we'll look back and say that, hey, I initially, patient came in with a rash. I went through this whole AI, chatbot thing, and it told me that I need to refer the patient to the dermatologist, which I already knew. So like, what is the new value addition that I'm getting from whatever that new fancy tool is? Is that actually going to change my decision making? Is it actually going to get the patient the care that they need or not? We need to be very thoughtful about those things.
And some people might be listening to this and say, you kind of mentioned first principles. One of the approaches to making sure you have all these first principles baked into your thinking is regulation. And that kind of brings me to, just very quickly before we wrap up, maybe just quickly talk about the regulatory aspects, because regulation kind of in some ways makes you think about, okay, well, what is the intended use here? Who is it for? Where does it fit into a clinical workflow? How is it being used? What are the risks? How do we mitigate them? How do we develop a quality management system to then implement this? And then how do we measure success? How are we setting ourselves up to generate the evidence for this? And then we can talk about the risk-benefit ratio, etc. Do you have any experience or views or perspectives on kind of like the regulatory picture for you, or like within India?
Yeah, so I think one of the biggest challenges is knowing what is the truth, especially if you're like in a post-truth era with social media, and I mean, but there's also we're also like in a pre-truth or post-truth era when it comes to public health and public health information, right? So if you look at the nationally representative health surveys, they happen for 4 years. The level of granularity goes down to the district, and those estimates of key health parameters vary significantly from what the official portal is showing for the same indicator, right? For the, if it's the maternal child health or TB, et cetera. So first of all, we don't know what the truth is, right? Now, if you're doing a proper sample survey, like that should be closer to the truth if it's a representative sample, but there's even questions if that's truly a representative sample or not. Okay, so we need to first start off by like understanding like what is the ground reality. But then on top of that, the issue is, okay, and I'll give you an example. TB free by 2025 was one of the declarations. You need to make these declarations to motivate people in a certain direction. And I totally agree with needing to have, SDG goals, health specific goals. But you have to couple that with the right monitoring and supervision mechanisms. And it has to be like we talk about SMART goals, right? It has to be specific, measurable, achievable, realistic, time bound. So is it real? Is it a realistic goal or not? Well, maybe not. Maybe we need to be more patient with kind of achieving these goals. Not to say that we should delay it, but really because it does take more time. So what's the fastest way to become TB free? the fastest way to become TB free is to report that there's no TB. That's it, right? It's simple. It's solved. You report that from my village there was no TB, and they have this campaign, TB free India, TB free Rajasthan, for example, and they're giving incentives for every screening that was done across. In Rajasthan, it's over 7,000 villages that they identified as target regions. So every screening you get 10 rupees. Okay, let's say there's 1,000 people in your village, you get 10,000 rupees. Great. ASHAs should be paid more. I would argue that they're underpaid, but they can easily just say that everyone was asymptomatic. They didn't collect any sputum samples of the cough, and they didn't have any TB in their village, and their village gets stamped TB free. And then they get to promote that, hey, we have these many TB free villages across the state. That's not right. I mean, if you're not actually going and screening people, and then you're declaring yourself as TB free, TB is not going to magically go away.
Is that what's happening on the ground?
Yeah. And you see, the unfortunate truth is that the health workers also have some fear of reporting the truth, that their higher ups, whether it's the nurse or doctor, or somebody's going to end up, they're going to receive some kind of punitive, feedback
for finding it.
For highlighting that this child died, or that this patient has TB, or that, their village is a problem area, right? So for some health workers, not everyone is a good apple. It creates more work and they don't want to do that. But for others, they have a genuine fear that there are going to be repercussions that come back to them for being honest and reporting the truth. So now they've coined this term, supportive supervision. So report whatever you want to report. We will support you and we'll supervise you in a supportive way, not in a gotcha type. And I think at least TB is moving somewhat in the right direction, because they also pay more for identifying cases, several hundred rupees for each positive case that's identified. And that's good, because if you don't identify the cases, you'll never stop the chain of transmission. The only question now is, how do you actually align the incentives and the supervision and the monitoring in a way that makes sense, that avoids cheating or misrepresentation of the data? Why should we even give 10 rupees for every screening if we're not meeting certain quality metrics in terms of the number of symptomatic cases that should be expected to be reported, the number of positive cases that should be expected to be reported, based off quality standards?
So part of your 3 I's that you mentioned was incentives. So I think that's a really great example of how it can unintentionally kind of mess things up, right?
Yeah, and I just want to clarify one other thing. I mean, ASHAs have told me, and one of the most powerful things that ASHA workers told me is that I get paid less than a daily wage laborer. So it was such a profound statement to think that, ASHA workers that are responsible for this huge drop in neonatal mortality, for example, are getting paid, $2 a day? And, they have a component fixed salary, they have a component incentive-based salary. They should be getting paid more. Why are they paying for their own data plans to report all this data? Why are they having to spend money to travel to the health center and sit with the data entry operator? They should certainly India and other countries should increase the percentage of health spending as a fraction of their overall GDP. And support the people on the ground. I'm totally for that. But at the same time, I also believe that we need to have better metrics to evaluate which health workers are really contributing to the impact of their communities, which health workers need more support, and appropriately allocate resources to help them. Whether that is on the basis of increased poverty index, which we can now measure, increased climate vulnerability, which we are now able to measure as well, using a new climate health vulnerability index that we've developed. We need to find ways to actually get resources to people that need them, and then the right capacity and skills to build them up.
One of my questions was going to be, in terms of challenges, how do you measure what bit of effectiveness, quality and performance tracks towards what's really valuable? How do you elevate the things that are harder to measure?
So we have international regulations for health data privacy, HIPAA, GDPR, etc. Now India has a patient data protection bill, which is a good step in the right direction, or personal data protection policy rather. But when it comes to regulation, there's still so much gray area, not just around sharing of information, but even if you look at regulation of these new technologies, right? So the AI for health technology.
Yeah, medical device regulation.
Medical devices, yes, to a certain extent, they do have standards for devices that again are catering to the public and private hospitals, but the regulation as you go more towards the community gets more diluted. And then the other question or concern that kind of underpins this is to what extent are patients that are or participants that are being enrolled in the studies to prove these things out, to what extent are they giving informed consent? What does informed consent look like for somebody who doesn't have that level of health literacy or even literacy, right? So do they understand the risks and benefits? Do we understand the tax that this could potentially put on the system by adding another technology? And I think that India is a unique place because of the chaos and gray area. You can innovate faster, but at the same time, when it comes to somebody's health, you have to be much more thoughtful. So it cuts both ways, and you want to stay away from areas where that output of your system could really make a big decision one way or the other. So we can use things like AI to help prioritize who we need to call back or who we need to visit at their home in terms of giving some kind of extra services or services that a human alone wouldn't be able to do. So more on the automation side, I think technology has a huge benefit to play. But when we start to get into prediction and now generation of new content, we need to be a little careful.
And who's overseeing this? What's the body that oversees this kind of medical device regulation in India?
So it's again evolving landscape. You have the Indian Council for Medical Research, ICMR. You have CDSCO for medical devices. Now there are new AI centers for excellence that just got announced. A lot of the All India Institute of Medical Science group is going to be looking after that. So it's emerging, and we need that. We need to build up that capacity and infrastructure to test the future of what public health technology and innovation will look like.
Great insights on the challenges. What's next for you guys at Khushi Baby? What are you kind of working on? What are you excited about?
Yeah, no, we just finished 10 years. I would say the first 10 years were all about getting our foot in the door and scaling up a digital platform in a complex environment and understanding the landscape. The next 10 years are hopefully making a big impact. So I would say the impact that we've made right now is more on the digital enablement front and on helping conduct big health census and identifying inequities in diseases. But now the next frontier is, okay, we've identified these many hundreds of thousands or millions of people at risk or with certain health conditions. How many of them got successfully referred, successfully treated, did not relapse from their condition? And that part of the kind of care delivery chain is the harder part to solve. It requires a more deeper collaboration with the government and with the other partners on the. So that is really our goal from a health system strengthening standpoint.
Mm-hmm.
We're excited that we're moving into 2 new states. Ultimately, our goal is for the technology platform to be adopted as a digital public good by the Ministry of Health of India. All of the solutions we are giving to the Department of Health free of cost. We want them to adopt a solution that works for the community health worker and for them at scale.
How do you make sure that you guys are able to be sustainable as an entity through that if you're doing it free?
Yeah, so the public health department is unique in that it's as a software provider, you're not going to be very satisfied if you function as a vendor. You're going to be a lot more fulfilled if you and able to make an impact if you work as a partner. So we've taken that approach as a development partner. Funding for us, there's still hundreds of millions of dollars that are being invested in the digital health space and in related health system strengthening space. Probably billions of dollars, in fact. I'd have to look and see how much India is getting out of that pie. But there's plenty of philanthropic support that is available. And if the government wants to engage in public-private partnerships through its own budgets, of course we would be open for that. But I don't think that the philanthropic capital is close to expiring. And I think that
is it hard to get access to? Like, would that be one of your challenges as well? Or is it on the spectrum for you to kind of make sure you get that
I mean,
funding?
there are organizations that are working in sub-Saharan Africa who have annual budgets of $25 million a year for doing digital health solution work at, we're talking about one third of the scale that we're working at right now.
Mm-hmm.
So there's certainly funding out there. I don't want us to be necessarily that resource intensive. I mean,
Mm-hmm.
I would argue that we're about 20 times more cost efficient than some of those other competitors or parallel colleagues in different
Yes.
places, peers. Yeah. But at the same time, yeah, there is funding available. I think what will happen with us is more of a shift from working on the core digital health solution to working more on the data analytics, health system strengthening, and the research and innovation piece. We want to switch from 70% working on the solution to 70% working on program delivery, analytics, and new ideas. So that's where we think we can make impact over the course of the next 10 years.
Great. Great to hear that. And great to hear that, the things that you're focusing on, I guess like really attached to like, the realities, because often you kind of hear pictures or like, what's next? Yeah. So we're going to do this thing with generative AI or this thing. And it's like, yeah, it sounds like very grounded in like what really needs to happen.
Yeah, I mean, I think generative AI, like it's got a lot of potential. It's the new sexy thing. Everyone's making a chatbot. We're making a chatbot as well for ASHA workers. But again, what the deeper question is, how do you ensure in a systematic way that it's safe, right? And I think that's something that people are working on how we can better solve that. We're super excited about. We have one of the probably the world's largest study to do machine learning on images of the inner eyelid to predict maternal anemia in the clinically relevant range to help with getting pregnant women iron transfusions, blood transfusions that will eventually protect them at the time of delivery from life-threatening bleeding and help protect their child from malnutrition. So we're working on, so you take the phone, you don't have to poke anybody, you don't have to draw any blood, you just take a photo, we estimate your hemoglobin level. We're working on that, but that's still going to take some time. It's going to need regulation. It's going to need community-based,
Mm-hmm. Mm-hmm.
trials and settings. And then ultimately, again, we still need to ask the question, is that screening tool going to meaningfully change how many people got the treatment that they needed? Even if it's much more cost effective than a handheld
Yeah.
device that you have to poke
Yeah.
somebody.
What's the kind of bigger clinical outcome that you're gunning
Exactly.
for? Is it moving the needle on that? Absolutely. Okay, let's wrap up. Do you have any other kind of key top takeaway for, someone who might be building kind of early in their journey, creating impact for underserved communities or kind of working in India or working to support community health workers? What's your top takeaway for them?
You have to visit the field. That is the most important thing. It's been part of our DNA from the beginning. You cannot build, from the comfort of your home. You have to go out and work and see what actually is going on before you introduce a new technology. The name of the initial class was called Culturally Appropriate Technology for the Developing World. Culturally appropriate, or having cultural humility is now a kind of a different way of phrasing that, is really, really important to understand this larger concept that we're talking about. Like, is this going to be something that actually moves the needle? Is something that we can actually co-create value? Not to think of ourselves as the problem solvers, but really to think of this as a collaborative effort, to think about how we can move things forward.
I think that's definitely a good takeaway, especially for anyone who might be building from the context of Europe or the US or the UK and perhaps going out to implement a technology in another part of the world, and kind of part of the why of this podcast as well, like making sure that we're learning from all contexts. Learning happens both ways, right? And so, yeah, I think that's a great thing to share.
And I think this platform, being able to have these honest and open conversations, exchange of ideas, that's such a key piece to moving the discussion forward and moving the agenda forward, because we this is a small community working in the global digital health arena, and there's a lot of change that we can make, but we need to do it together.
Definitely. Ruchit, I'm really, really grateful that you have shared your experiences, your insights, the impact that you've had, the challenges that you've tried to overcome. Thank you for your time, Ruchit. Thank you.
Thank you so much.
Before you go, a quick word. I started this podcast to expand all of our perspectives. I think it's really, really important that we do that and learn from people who are really solving complex issues with implementing, particularly for underserved populations. We can learn a lot about solving challenges around health equity, ethics, implementation science, generating the right evidence, etc. But from the perspectives of these places where it's even more challenging often. So people who are kind of, elbow deep in these problems have so much unique insight to share. So if you found this useful, or know someone who will, please hit follow on your podcast channel. Check out the website, gpodh.org. We're also on YouTube, so you can subscribe. And also we have a LinkedIn page, Global Perspectives on Digital Health, and share that with those who might find this interesting as well. If you have insights to share or know someone who it would be great to have their insights on this podcast, then do get in touch through any of those means. And if you're a donor or social impact investor and you have startups that have some insights to share, then do get in touch. The stories that we have here are really, really incredible, and it's a really unique way of communicating the impacts. So please do get in touch as well. Great.